Welcome back to EP Edge Journal Watch. I'm Dr. Sharma, and today we're doing something a little different. This isn't just a tour through new papers. This is an episode built around one core question. What does success actually mean after atrial fibrillation ablation at 1 year, 4 years, and even 20 years? And here's the uncomfortable part. Sometimes the success rate you hear is not biology, it's monitoring, its endpoints, and its definitions. Then we pivot to two practical problems you will actually face in the lab: ablation in patients with implanted devices and pacing-induced cardiomyopathy in the leadless era. Here's the roadmap. First, ADVENT long-term outcomes, the ADVENT-LTO extension. This matters because ADVENT has been the most comprehensive two-arm, well-monitored comparison of pulsed field ablation against thermal energy in paroxysmal AF. Second, a 20-year follow-up cohort from Hamburg that tells you what durability looks like when you zoom all the way out. Third, a JACC clinical EP paper that basically argues we're comparing trial results the way people compare car mileage stickers without checking how the test was run. And then two reality checks: the MAUD signals in ablation plus cardiac implantable devices patients, and the pacing-induced cardiomyopathy data comparing leadless versus transvenous RV pacing. All right, let's start with the headliner. Study 1, ADVENT-LTO. If you've heard any criticism of pulsed field ablation, it's usually this: sure, it's safe, but will it last? ADVENT-LTO is the first randomized platform extension that directly addresses durability over roughly 4 years, and I want to frame the headline carefully. The headline is not PFA wins by a mile. The headline is the effect does not collapse over time, and the downstream events that patients actually feel trend in the right direction. Let's get the basics straight. This was an observational long-term extension of the randomized ADVENT trial. So we're no longer in the clean world of perfect randomized follow-up. The extension enrolled 364 patients, 183 in the pulsed field group, 181 in the thermal group. Follow-up was about 1,332 days on average. Think of it as roughly 3.6 years after the index procedure, extending to about 4 years total. Now, before we even touch the outcomes, we have to talk about the silent driver of success rates: monitoring. In the original pivotal year of ADVENT, the monitoring was intensive: weekly transtelephonic monitoring from months 3 through 12, ECGs at 3, 6, and 12 months, and 72-hour Holters at 6 and 12 months. In ADVENT-LTO, the extension monitoring was closer to real-world, retrospective chart review plus independent core lab review, and then a prospective 7-day Holter at 4 years, but only in a subset: 138 in the pulse field group, 119 in the thermal group. Why does this matter? Because if you don't look as hard, you find less AF, and your success rate looks better. So in long-term extensions, you should interpret success as clinical success more than no 30-second episodes ever. Okay, outcomes. The primary endpoint was 4-year treatment success: 72.8% with pulse field, 64.1% with thermal, p-value 0.12. Translation: that's about a 9% absolute difference, clinically suggestive, but statistically not definitive. So you can't stand on a podium and claim superiority based on the primary endpoint alone. But the more interesting signals are the downstream events. Freedom from hospital-based arrhythmia intervention was 85.6% with pulsed field versus 78.6% with thermal. The hazard ratio was 0.64 with a confidence interval crossing 1. So again, a trend, not proof. Now, the cleanest hard signal in this dataset is repeat ablation, 10.4% with pulse field versus 17.7% with thermal, p-value 0.04. That is not marketing. That is a tangible difference patients feel and health systems feel. And if you do a crude back of the envelope, that's roughly a number needed to treat around 14 to prevent one redo over about 4 years. Context matters, but direction matters too. Progression to persistent AF was low in both groups, 2.6% with pulse field versus 4.6% with thermal. Hazard ratio 0.55, but a very wide confidence interval. That's basically telling you event rates are low and the study is underpowered for progression. So what do I take to rounds from ADVENT-LTO? 1. The durability argument against pulsed field gets weaker, not stronger as time passes. It doesn't look like the lesions fade out early. 2. Even if the primary endpoint is statistically neutral, redo ablation and hospital-based interventions matter. Those are the outcomes that translate into quality of life and resource use. And 3. Always ask, how hard did they look? Because the success rate is inseparable from the surveillance plan. Quick clinical translation before we move on. If you're in clinic and a patient asks, Doc, does pulsed field last? My answer is, we now have randomized comparative data out to about 4 years, and the durability signal is reassuring. Not because every endpoint is statistically superior, but because the curve doesn't fall apart and fewer people need to come back for a redo. And then I add the honest qualifier. Long-term outcomes depend on more than the energy source. It depends on atrial biology, risk factor control, and whether we're measuring no recurrence at all versus a life that feels normal again. That theme is about to show up again in a big way. Now let's zoom out, because 4 years feels long until you look at 20. Study 2, 20-year pulmonary vein isolation outcomes. This is the Hamburg cohort from the early 2000s. Symptomatic drug-refractory paroxysmal AF, treated in 2003 and 2004 with RF circumferential PVI, and PV isolation was confirmed with the double lasso technique. N was 154. Median follow-up was about 19.3 years, and recurrence was defined as symptomatic or asymptomatic atrial arrhythmias longer than 30 seconds, documented by ECG, Holter, wearables, or devices, no predefined blanking period, and death was handled as a competing event. Here's the part I want you to feel in your gut, because it changes how you counsel patients. Median recurrence-free survival after the first ablation was about 4 years, and by around 19.5 years, AF or atrial tachycardia free survival after the first procedure was about 26%. So if you're thinking one procedure, lifetime cure, this paper politely walks you out of the room. Now, you might say, okay, that's single procedure. What about the real-world strategy, multiple procedures plus meds? Multiple procedural success at about 19.5 years was still around 25%. The cohort averaged about 2 ablations plus or minus 1, and about a quarter were still on antiarrhythmic drugs at last follow-up. More than half underwent at least one reablation. 53% had redo work, with a distribution that included multiple procedures in a minority. And atrial tachycardia ablation occurred in about 11%. One nuance I love in this dataset is the timing of redo work. In years 10 through 20, only 11 reablation procedures were performed, so the redo burden didn't explode late. Most of the repeat work happened earlier, which is exactly how many of us experience it clinically. It's not that nothing happens after 10 years, it's that late events are a smaller phenotype, and the mechanisms often look different. But here's the mechanistic pearl. Very late recurrences, meaning after 10 years, occurred in about 8% overall, and specifically, more than 10 years after the index PVY, it was about 3%. So late recurrences are real, but they're not an epidemic. Now, in patients who underwent redo after a very late recurrence, their redo mapping data are fascinating. PVI durability was 83%, 30 of 36 veins still isolated, and all pulmonary veins remained isolated in about 2/3 of those patients. So what's the implication? If someone shows up 10 to 20 years later with AF or atrial tachycardia, the pulmonary veins are often still isolated. That pushes you toward non-PV triggers, progressive atrial cardiomyopathy, or organized atrial tachycardia mechanisms. Not reflexively, the lines opened. And this is where I think the field sometimes focuses on the energy source. Even if pulsed field gives us better pulmonary vein durability, and it probably will, the 20-year ceiling may still be atrial cardiomyopathy. Blood pressure, obesity, sleep apnea, alcohol, metabolic health, endurance extremes, aging, those variables keep pushing the atrium in the wrong direction for decades. So the future durability conversation is likely a combined conversation. Better lesion sets plus better upstream therapy. Now, the anticoagulation section always triggers questions, so let's handle it responsibly. In this cohort, 48% discontinued oral anticoagulation during follow-up. Among those off anticoagulation, 73% were in stable sinus rhythm at last follow-up, but the median CHASVA score was still 2. There were 2 strokes off anticoagulation, both in higher risk patients, and overall, thromboembolic events were 7 across the cohort over 2 decades. Major bleeding was rare, but there was 1 fatal major bleed. So yes, it's an interesting signal. No, this does not justify stopping anticoagulation purely because the ablation worked. So what's the clinical message from 20 years? 1. Ablation is not a one-and-done lifetime cure. 2. Very late recurrence may not be PV reconnection, so don't oversimplify the mechanism. And 3. The ceiling on long horizon rhythm control may be less about lesion technology and more about atrial biology, aging, and upstream risk factors. Okay, now we're ready for the paper that ties these 2 studies together. Study 3, Defining Success After AF Ablation. This JACC Clinical EP paper is essentially a reality check on trial design. It argues that AF ablation trials often look in conflict because they are not measuring success the same way. And in the PFA era, those differences get amplified. They focus on 3 design choices that drive most of the confusion. 1. How intensely you monitor for recurrence. 2. What you call recurrence, usually the 30-second rule. And 3. The blanking period, whether it's 3 months, 2 months, or shorter. Let's start with monitoring intensity, because this is the quiet source of misleading comparisons. Low intensity monitoring misses asymptomatic AF, and reliance on patient reporting can overestimate success by 20% or more. High intensity monitoring, especially continuous monitoring, detects more AF. It lowers the apparent success rate, even if patients feel dramatically better. They discuss implantable monitors as a gold standard for detection and burden assessment, but adoption is limited by practical barriers. So the question becomes, if you're not doing continuous monitoring, what is enough intermittent monitoring? They cite strategies like 4 7-day monitors every 3 months or 2 14-day monitors every 6 months. Either way, you're sampling about 28 days per year. One of the most practical recommendations in the paper is this idea of dual reporting. Report outcomes under the trial's actual monitoring protocol, but also report outcomes under a standardized monitoring framework so trials become comparable. EP Edge translation: if 2 trials used different monitoring intensity, do not rank technologies by the headline success rates. First ask, how hard did they look? Now the 30-second rule. Most trials define failure as any atrial arrhythmia recurrence lasting 30 seconds or longer after the blanking period. The paper critiques this as a convenient binary endpoint that doesn't map well to clinical meaning. A patient can be labeled a failure for a short episode while experiencing a huge quality of life improvement, and a patient can be labeled a success while meaningful burden persists, especially if monitoring is light. That brings us to the metric that often matches what patients actually experience: AF burden. They highlight that burden captures how much AF exists, not just whether a stopwatch crossed 30 seconds. 2 classic examples make the point. In Discern AF, freedom from 30-second recurrence was 46%, yet AF burden decreased 86%, from about 2 hours per day down to about 18 minutes per day. In Circadose, with continuous monitoring, freedom from 30-second recurrence was 50%, yet AF burden dropped more than 99% after ablation. This is why a binary endpoint can call the trial mediocre while the patient experiences a win. They also make an underappreciated point about burden thresholds. With non-invasive monitoring, the burden threshold associated with quality of life impairment and healthcare use has been closer to 10%. but with continuous devices, the threshold can be closer to 0.1%. Let that sink in. 10% burden is about 2.5 hours of AF every day. 0.1% is about 1.5 minutes per day. So if you change the monitoring method, you change what meaningful burden looks like. That's why burden is powerful, but also why it demands context. Finally, the blanking period. Historically, it's been 3 months because early arrhythmias can be transient. But the paper notes that later blanking period recurrences predict late recurrence, leading to recommendations like 2 months for thermal ablation. For PFA, they argue the injury profile is different, less inflammation and less chronic fibrosis. And in a multi-center series, recurrence in the 2nd or 3rd month after PFA was strongly associated with late recurrence. So they suggest 1 month might be an appropriate blanking period for PFA. But, and this is important, they also emphasize the need for prospective validation. Let me give you the EP-Edge critical appraisal version you can use on rounds. When someone quotes an ablation success rate, ask 4 clarifying questions. 1. What was the monitoring intensity? 2. What was the endpoint threshold? Was failure 30 seconds? 3. What blanking period did they use and how did they handle events inside blanking? And 4. Did they report burden and with what monitoring? Or did they only report time to first recurrence? If those aren't aligned, comparing technologies based on headline efficacy is closer to marketing than science. All right, now for the first reality check that changes your workflow tomorrow morning. Study 4. Ablation plus implanted devices, the MAUD signal. This paper is a workflow paper disguised as a database analysis. They use the FDA MAUD database plus a literature synthesis from 2020 through 2025. They report 433 adverse events in CIED patients during or after ablation. And the point is not incidence because MAUD has no denominator. The point is pattern recognition. Here are the patterns that matter in 2026. Ablation catheter or energy was implicated in 97% of reported events. Most reports involved radiofrequency, about 89%, and pulse field was about 8%. Mechanical interactions were common with lead dislodgement as a major component. Now the new failure mode signal. Pulse field accounted for all confirmed generator failures in this dataset, 6 cases, and lattice tip RF near biotronic defibrillator leads was linked with VF induction in the majority of RF-related VF reports, 14 out of 15. That is a very specific pattern, and when MAUD shows you a specific pattern, you should update your mental checklists. They also provide a supplemental categorization that is useful, as long as you remember its distributions, not incidence. Lead dislodgement was 33% of RF reports versus 3% of pulse field reports. Resets were 5% with RF versus 29% with pulse field, and device damage was 0% with RF versus 18% with pulse field. Again, those are report distributions, not denominators, but they highlight where vigilance should be concentrated. The unsettling message is this: threshold rises and device issues can occur even when ablation sites are remote from the lead tip. So our simplistic just stay away from the lead tip heuristic is incomplete. Here are the actionable workflow implications. Prefer programming changes over magnet use when feasible, because magnet effects vary by manufacturer and can be unreliable in long cases. In pacer-dependent patients, consider asynchronous pacing with higher output during ablation. While recognizing it doesn't prevent every failure mode, be specifically cautious with lattice tip RF near biotronic ICD shock coils and pulse field in proximity to ICD leads or generators. And if interrogation fails post-ablation, troubleshoot the mapping system off before committing to generator replacement and involve the manufacturer early. My practical EP checklist sounds boring, but it prevents disasters. Before you start, get a true baseline interrogation and save it. Decide in advance whether you're using magnet or reprogramming and document why. For ICDs, confirm tachytherapies are appropriately managed and make sure external defibrillation is ready. For pacer-dependent patients, think about asynchronous pacing with a safety margin on output. During the case, minimize catheter contact with leads, but don't let that be your only plan. And after the case, insist on a full interrogation, thresholds, sensing, lead impedances, battery status, and a printout that lives in the chart. That's how you turn a scary database signal into a safe, repeatable workflow. Okay, second reality check. Pacing-induced cardiomyopathy in the leadless era. Study 5, PICM, leadless versus transvenous RV pacing. This is a TriNet-X federated EHR analysis of de novo leadless ventricular pacemakers compared with transvenous ventricular pacemakers. They looked at implants between January 2016 and January 2023. They excluded prior heart failure, baseline ejection fraction under 50%, prior devices, or CRT at index admission. The primary outcome was pacing-induced cardiomyopathy, defined as new heart failure diagnosis or hospitalization with reduced EF, or EF declined to under 50% after excluding other etiologies. They did 1-to-1 propensity matching, and the matched cohorts were large, 2,594 leadless and 2,594 transvenous. Here's the key result. PICM incidence was 7.6% with leadless and 8.6% with transvenous, not statistically different. And in the classic high burden situations, complete heart block or AV node ablation, it was basically identical, 10.3% versus 10.4%. So the physiological lesson is straightforward. PICM is driven by RV activation physiology, not by whether there is a lead in the pocket. But here's the subtle management signal that matters. CRT upgrades were less frequent in leadless recipients compared with transvenous recipients, and the likely explanation is not physiology. It's practical barriers, patient selection, infection risk, vascular access, reluctance to add a second system, and evolving comfort with extraction strategies. So the implant counseling takeaway is this. Leadless may simplify early infection and lead complications, but it does not PICM-proof RV pacing. If the pretest probability of needing CRT or conduction system pacing later is non-trivial, that should be explicit at implant time. All right, let's close this out by tying the entire episode together. Closing and takeaways. If you only remember 5 things from this episode, make them these. Number 1, ADVENT-LTO shows that pulsed field ablation durability does not wash out over time, and the clearest heart signal is fewer redo ablations versus thermal energy over about 4 years. Number 2, the 20-year Hamburg cohort reminds you that AF is a progressive atrial disease, and long-term durability is not a single curve, it's a lifetime biology problem. Number 3, very late recurrence often occurs with pulmonary veins still isolated, which should shift your mechanism thinking toward non-PV triggers and atrial cardiomyopathy, not reflexive PV reconnection. Number 4, when someone quotes a success rate, ask the 4 questions: monitoring intensity, endpoint threshold, blanking period, and burden. And number 5, the real-world safety signals matter. MAUD can't tell you incidence, but it can tell you new failure modes, like generator failures reported with pulsed field and VF patterns with specific RF platforms near specific ICD leads, and leadless ventricular pacing does not reduce PICM risk compared with transvenous RV pacing, so physiology still wins. As always, all details, graphics, and references are available on Substack at epedge.substack.com and also on the LinkedIn newsletter EPEdge Journal Watch. Thanks for listening. Until next time, stay sharp, stay curious, and take care of yourselves as well as your patients.